All right, guys, I am back. Um, I thought I was back. I think I have a lot of Gatorade for this last portion. Hopefully, we can get through it. So, we're going to talk about SIRS and MODS. SIRS is systemic inflammatory response syndrome. So, you can have this for quite a few different reasons, but basically, you have generalized inflammation, um, and that's happening in organs that are not necessarily involved in the initial thing that's going on. So you have all kinds of reasons that we can have this. So you see those here. We have like tissue trauma such as burns, injuries. You have microbial invasion. You're going to see that with bacteria, viruses, fungi. You're going to see like if your pancreas is basically the ischemic issues can be like pancreas is just one option, but you can have the vascular. You can see it with even an MI or um, with an abscess, and then with shock and with issues with perfusion and resuscitation. So, MODS is a failure of two or more organ systems um, that's going to go with this. So, it's when you cannot maintain your homeostasis without interventions, and yeah, we're going to have all kinds of issues. Um, so just kind of looking at the relationship between shock SIRS and MODS. This is a table that's in your book. So we see, you have all those different types of shock that are up there. And then these are leading to SIRS. So you see all the different like things that can happen there. The cytokines are released. You have all kinds of injury and dysfunction. You have the vasodilation, increased capillary permeability that we've talked about, leading to the edema. And then you're going to see all these other systems that are going to start having dysfunction. So we have a case study here. We have KR, 28-year-old woman brought to the ED by her mom, confusion, fever, and what they thought was the flu. She's been vomiting for 2 days, has generalized edema. Temperature is 103.5, heart rate's elevated, respiration's elevated, blood pressure is low. So we're going to kind of talk through her as we talk about SIRS and MODS. So based on these vital signs, like what would she be at risk for? So obviously, we need to think about decreased perfusion, just the low blood pressure. And we could think about maybe coagulation for her. We could be wondering if she has edema. And yeah, we'll keep going and we'll see some of the things that we need to watch out for her. So we're really focused on the inflammatory response here. So we're having a release of mediators. The endothelium, which is the layer around certain organisms, can be damaged. We're going to have the hypermetabolism that we've been talking about. I feel like I'm just repeating myself over and over today because it's all just so related. You're going to have that increased vascular permeability. You're going to see white blood cells beginning to digest like foreign debris, and then you may have activation of that coagulation cascade as well. So once again, we have the hypotension, which is leading to the decreased perfusion, which is leading to the redistribution of blood flow, which is leading into the compromised organ dysfunction. So say it over and over, but those are really what we are focused on here. So as far as the patho for the SIRS and MODS, the respiratory system is often the first one that's going to show signs of dysfunction in this situation. Don't worry too much about these terms, but we'll focus on the nursing management here in a minute. But this is just some of the stuff that you may end up seeing. Cardiovascular wise, what we've been talking about, the vasodilation, decreased SVR and BP, increased heart rates trying to compensate for that hypotension. You're going to see that albumin in the fluid move out of the vessels, and then you're ultimately going to see dysrhythmias if we don't get this corrected. Um, so neurologic system, obviously you're going to have the mental status changes due to the hypoxemia. You're going to have the impaired perfusion's going to end up leading to confusion. You may even see like agitation. People are going to be combative, or you may see the lethargy. And these are often, some of these neurologic changes are often also some of the early signs of MODS. Uh, for the renal system, once again, a lot of the drugs that we're using for some of the other systems are going to be hard on the kidneys. And we do have the hyperperfusion as well. Oh, and yeah, the antibiotics are one of the big ones that can be hard on the kidneys. So as far as the GI system, you've got your decreased motility, which is going to lead to distension and ileus, and then you've got your decreased perfusion, which is leading to the ischemia and then the ulcers and the GI bleeds. We do have to be worried about um, the DIC that can happen from the dysfunction of the coagulation system. So that's when you may have like clotting and bleeding issues at the same time. I guess I skipped over the hypermetabolic state. So our glycogen stores are very, very rapidly converted to glucose, and then our amino acids have to be converted to glucose once the glycogen's gone. So we're reducing our protein stores. Um, so you end up getting hyperglycemia, you end up getting insulin resistance. You're going to end up losing the lean body mass. And then as your liver continues to have more and more dysfunction, your body's not going to be able to convert that lactate to glucose. So then eventually you may end up having hypoglycemia, but that's usually quite a bit later on. Obviously, we're going to see the electrolyte imbalances. Hypokalemia and hypocalcemia are going to develop as those electrolytes move into the cells. And then you're going to see metabolic acidosis. So our friend is going to be admitted to the ICU with potential sepsis. Her urine output is only 15 mils over 2 hours. And you remember what we want our urine output to be. Hopefully you said 30 mils an hour. We want 240 mils every 8 hours. So kind of looking at the overall, but obviously she doesn't have enough here. Chest x-ray showing infiltrates, white blood cell count, and lactic acid are high. So can you think of any nursing diagnoses and goals for this patient? And then what assessments are high priority for her? All right, so let's talk a little bit about that. So prognosis is poor for MODS. We basically want to prevent the progression. We want to be really good at in-depth assessment, monitoring, detecting the early signs of any kind of organ dysfunction so that we can get it fixed. Mortality rates when it gets to this point is about 40 to 60%. Okay, so we're focusing on treating infection. We are focusing on maintaining our tissue oxygenation, nutrition, metabolic support, and then just thinking about all those failing organs. So we put a catheter in our friend. She also got a central line. The healthcare providers are talking to her mother about possibly putting her on a ventilator. Her mom asked why she's so sick and what can be done. So what are the other things that may end up happening that we would want to talk to her mom about? Um, it's just something to think about because we do have to deal with family a lot and how to talk to them. So obviously we want her mom to anticipate like antibiotics, but also, sedation and nutrition and all that kinds of stuff that her mom's going to have to be making decisions about. So we're working on preventing and treating infection. So sometimes infection is what caused this, and sometimes it's not necessarily, but we certainly don't want an infection to develop because that's just going to make everything worse. So really being strict with our, cleaning our lines for the right amount of time before we use them, and wearing gloves, cleaning our hands before we go in the room, all that kind of stuff. Making sure that we're not having too many lines that we don't need. Do we really need, the central line? Do we really need the Foley? What is absolutely necessary here? And then the aggressive pulmonary management. Once an infection is suspected, we're going to try to deal with that with obviously the antibiotics, and then really quickly thinking about getting them to surgery to remove any necrotic tissue that the antibiotics are not going to be able to take care of. We're focused on our tissue oxygenation. Sometimes we're going to use the sedation, use the vent, the pain meds, the rest, all that kind of stuff to make sure that we're decreasing that oxygen demand. And then once again, nutrition therapy. Our total energy need is 1.5 to 2 times higher than it is in normal life. So we're really focused on just preserving that organ function. Okay. Got a case, a little bit more to our case study, petechiae, jaundice skin. So jaundice, we're going to be kind of thinking about that increased bilirubin related to the liver, and wondering if the liver is starting to have some issues. The petechiae could be related to, the clotting issues or DIC. So we're going to real quickly try to manage and treat this. Probably going to, focus on the oxygen, getting oxygen everywhere it needs to be. So patients are at this point probably going to be on the ventilator. Let's see, we talked about all that. Yeah, just communicating with the family about realistic goals and outcomes is going to be important at this point. I got a couple more questions. I'll let you read these and then we'll talk through the answers. My voice is not going to hold up, so I'll give you a second to read this question, and we'll talk through it. Okay. So the answer was B, pulmonary edema. And that is because the respiratory system is often the first one that's going to show signs in a SIRS. So increases in the capillary permeability are going to facilitate the movement from the pulmonary vasculature into the interstitial space, and then the fluid's going to move to the alveoli, and then we're going to have that edema and pulmonary edema. And that's often going to be one of the first things we're going to see. Here's another one for you. This is the last one, I think. All right, what do you guys think? That's maybe a little trickier. So focus on that we're in late stage shock. We're already kind of to the SIRS. So the answer here is the 100% oxygen. So this patient's going to yeah, it's just going to be our priority. It is one of the first things that is going to go downhill, like we just talked about in the last question. And it's also a very quick thing you can do. So throwing a non-rebreather on a patient at 100% oxygen is going to take you, 10 seconds if you have it sitting there in the room with you, versus some of the other steps are going to take quite a bit longer, inserting the two large bore IV catheters, um, inserting a Foley. Like, yeah, we want to monitor their urine output, but that's not the end of the world to know exactly what their urine output is right at this moment. Um, you probably are going to insert some catheter or some IV catheters, but the oxygen is just a real quick thing that we can focus on to help with our perfusion. So, all right, let me see. I think that might have been it. Yes, it is. All right. So if you guys have questions, you can message me. I feel like these last two videos were a little better. I'm sorry, I was so just all over the place last night when I was recording the first video. So I really want to redo it. The perfectionist in me wants to, but I'm not going to. I'm just going to leave it for you guys. Ignore my 1,000 water breaks I had to take and just shuffling all over my notes that I was disorganized with. But hopefully it all still made sense, and we can talk more about it in clinical. So, and hope you have or have had a good Labor Day. I will see Caitlin. I'll see you on Tuesday.